if you're trying to consider whether they'd be amenable to a minimally invasive treatment. Again, thank you very much.
Gary, thank you. Absolutely amazing. Some of the cases that you're taking on with minimally invasive techniques, I think many of us would probably be using open surgery for those. So it's quite inspiring actually to see that from a surgical point of view. We've got a couple of questions, I think from patients, although I may be wrong about that. Benita writes us, do insurance companies cover needle aponeurotomy? I think this will be country dependent, but how is it in New Jersey?
Needle aponeurotomy is covered by Medicare and all insurances in the United States. They're very kind to pay for one finger, even if you do four, but that's just the way it is. But it is covered. It's an approved procedure.
And Paul, can you give us a European view on that?
Yeah, well, I wasn't aware of that until later, but as a result of our RCT, where we compared the needle fasciotomy to the limited fasciectomy, at least in Holland, the insurance companies decided to start to reimburse needle fasciotomy because it was quite a new procedure in those days. I do not know how it's in other countries, but I think that in most countries it's actually being reimbursed. And as most of you will know, this procedure was really popularized by rheumatologists in France, and both Gary and Charlie Eaton and myself and most of the other people who started in the early years of this millennium went to the same hospital in Paris to see how these people were doing it. So we owe them a lot.
We're absolutely indebted to them. There's no question about it. In other talks I've given, I've shown pictures of, our mentors from there, Dr. Vaudois, Dr. Lemisseau.
Yes,
yeah.
That was great. Yeah. Can I ask a few questions to Gary, Dominic?
Go for it, Paul. Go for it. We have some
Gary,
from the audience as well, but yeah, you go first.
Gary, I was also impressed by the results that you're achieving. Your results are much better than mine. I think I'm a bit more chicken in these contractures, I think. But one of the things that I wonder, many of these cords that bend the PIP joint, they end on the A4 pulley. So it's a lateral digital sheet cord that actually ends via Grayson on the A4. And I saw that you actually tried to release them, or did successfully release them with collagenase. And I thought that was a relatively tricky maneuver. Can you explain a little bit how you prevent the collagenase to get too close to the tendon?
I mean, it's obviously very difficult. I mean, with the needle, you can easily release centrally, proximal to the A4 pulley, and get those fibers that crisscross over. It's probably impossible to put collagenase in that area, but I think that if you concentrated enough just proximal to the middle digital crease, you could be effective enough at getting, right where it junctions off. Maybe not perfectly, but you can put it proximal and distal to the middle finger crease or middle digital.
Okay. I also noted, Gary, that in some of the cases that you so nicely showed, you used a whitish fluid. I presume that was steroids, and in others you didn't. So can you explain to us when you do use steroids and when you don't, in addition to the needle?
The traditional way we were taught, and is the way I've continued, is to fill a 5 cc syringe with 3 cc's of 1% lidocaine plain and 1 cc of depomedrol, which is 40 milligram depomedrol. The last patient, the one that I did PIP and DIP, you could see there was just xylocaine in the needle. That patient was diabetic. So if patients have diabetes, I don't use the cortisone for fear of, causing some increase in their sugar. But I generally do use cortisone for all the patients. I can't tell you the advantage, except that, certainly some of the studies of Ketchum, Binhammer have shown that cortisone does slow down the growth of the collagen. And I do, I also use steroids for patients who don't have a contracture yet to try to prevent a contracture by injecting their nodules and early cords. And
Okay,
that's
thanks.
publication.
Well, I personally, I never use steroids. I don't know. Joachim, what do you do? What do you do?
I use steroids, but of course, if you look at this paper by Macmillan, the evidence is quite weak, and they use serial injections. It's not the way we use it. I used the same mixture as Gary, actually, but in that series, they took the patient back for consecutive injections. So there still need to be more studies on the effects of corticosteroids. I just want to comment on this, that I'm not at all as bold as you are, Gary. I'm very impressed with what you can do, but let's just ask you about the night splints. I've turned to not using splints for singular MCP contractures. If the patient can extend their finger actively, then I usually never use it. But most PIP contractures, I use it. But what about you? You use night splints for all patients, or do you differ?
My usual protocol is to use a night splint for all patients. Though I agree with you, the MCP joints probably don't need to be splinted. And again, I don't really have any absolute evidence. I think what it does two things. One, it gets the patient involved in their care. I'm telling you to do this, please do this, and watch it. It also shows them they can get their recurrence rate, that recurrences are identified much earlier, because when they're having more difficulty putting the splint on, it becomes harder to put it on. They're more likely to come back. I try to redo a minimally invasive technique before they're 50% back recurrence-wise. So if they start at 60, I want to do it again at 30. I think it's easier. The tissues are more supple. And I think that's one of the techniques that gets patients to come back a little bit quicker. But I also use relative motion splints. If you find that by flexing the MP, the PIP straightens, where if you let go, you have something like this, a relative motion splint flexing the MP joint may help the patient during the day as well.
Very interesting, yeah.
Okay, we've got quite a lot of questions from the audience. There are three of them which sort of coalesce around complications and recurrence. So Pat Wald wants to know about recurrence and residual pain. Joshua Colo is a musician and a guitar player, and he's asked about nerve damage and would he be able to play his guitar again. And then Jesper Nordenskjold wants to know about the incidence of flexor tendon injury and digital nerve injury, and do you think the complication rate is underreported? So tell us about complications.
Complications are the nemesis of any surgeon, certainly in the hand. With collagenase, my number one fear is flexor tendon injury, about 0.1% in publications. Using some of the techniques we described, staying close to the proximal digital crease until you're super confident and go more distal, and using smaller amounts, but in different places, will hopefully keep the collagenase from getting near the flexor tendon. For needle fasciotomy, the number one fear is nerve injury. I think the incidence of nerve injury is low, probably in the less than 1% range, but can be significant. The good part in terms of musician, if you get a digital nerve injury, it's going to be half of your finger. So you're not going to have numbness of the entire finger, generally going to be in the distribution of one of the nerves. And usually, in my experience, most of them are temporary, a temporary neuropraxia, either from stimulating the nerve or from stretching the finger. But nerve injury is definitely, and that's why we want the patient awake. That's why we want to know every time we put the needle in if they feel an electric shock, constantly talking back and forth with the patient. But there's nothing that we ever do that has a complication rate of 0, for sure.
Yeah.
In terms of pain, in terms of the question about pain, I think the pain post fasciotomy is very low. I give no prescriptions for any of my fasciotomy patients unless they're one of the ones that are like this. Pain levels generally low, maybe a little bit of swelling. Certainly with collagenase, the possibility, as we heard earlier, the possibility of pain is higher. due to swelling, bruising, and some of those patients do require some analgesics. And Americans are wimps anyway, so we have to be on the lookout.
So that leads on to Devin Scott has asked, what about the feeling and pain during these procedures? How do patients describe that? So I think that's a very interesting question, because like you, I use a tiny little bit of anesthesia for my PNF. I'd really just want to anesthetize the skin where the needle's going through, so that if I do touch the nerve, my patient tells me. What does it feel like to have a PNF or to have collagenase?
In my experience, I mean, for the original description of collagenase was without any anesthesia. And I think after we did 20, 30, and most experience, I know Dr. Hurst is on the call as well, you started anesthetizing the hand. So I anesthetize the hand pre-injection, avoiding anywhere near the cords so that I don't put fluid around the cords so I can't palpate them. And for manipulation, as you saw, I do PIP block, dorsal block, median nerve block, ulnar nerve block, digital nerve block. And, I anesthetize them and I come back, 15, 20 minutes later. So the manipulation should be relatively pain-free with proper anesthesia and care until afterward, when it certainly could hurt when the patient goes home. Needle fasciotomy can hurt. I mean, there is no question. You're putting 25 gauge needles in the hand repeatedly. Patients, you need to coax the patient. I know Charlie Eaton tried vibration as a technique. We have good music on. We try to distract the patient. Some patients can't tolerate it. I mean, there is no question. It is not for everybody. This is a wide awake procedure without complete anesthesia. You cannot completely anesthetize the hand safely. I do PIP joint blocks, which help on the manipulation. And I have had patients where I will needle them completely awake. And when I put my needle down, I will give them some Versed, Diprovan. Some of the patients are in, an outpatient operating room, and then I can crank on the finger as hard as I want. And I think that helps. But at that point, I'm not putting a needle in. Hope that answers that question.
Thank you. We have TJ Brindley, who wants to know, how do you decide whether to choose collagenase or PNF? You seem to have excellent results with both of them. How do you decide between those two?
I mean, in my practice, a lot of it's self-determined by the patient referring themselves. They've already predetermined what they wanted. We have John Elway on TV now in the United States advertising for Xiaflex. They've seen the commercial. They want to be just like him and get the same thing. A lot of patients travel far. I saw a question earlier about obviously the convenience. If you're traveling far, and that depends on any of the countries we're dealing with around the world, it's obviously easy to do PNF. It's come in, do it, go home, and you're done. With collagenase, I like to have the patients come back a week later, so it would be very inconvenient. And again, if the patient has that really thick, wide nodule over the proximal phalanx, maybe tree trunks between the beads, as Paul has explained to us, which I like that description very much, then I might opt pushing for collagenase rather than needle. But most of the times, at least in my population, the patients are the ones that decide.
Fair enough. Paul?
Gary, I was intrigued by that patient, that 55-year-old patient with a positive family history, alcohol enjoyer, PIP contracture, multiple procedures in the history. In my hands, those releases are not at all durable. How is that? How is that in your hands?
I 100% agree with you that as we saw in the recurrence papers earlier, patient like that has a much higher recurrence rate. If I can get them, if I can get that 75-degree contracture to 15 to 20, they're usually happy. And then I try to repeat it when they get back to 30, 35. Again, I like that 50% range. But by no means am I telling the patient, I'm going to make you perfect and you're done. If you've already had two fasciotomies done elsewhere, this patient also had iodine treatments, not exactly sure what that was, strong Dupuytren's diathesis. but I have not repeated my procedure on him. But, I'm
Okay.
sure he has recurrence, and I'm sure his recurrence is 20 degrees and were considered by our means and the papers to be recurrent Dupuytren's.
And would you, if he had recurrence, try again with the same procedure? Or when do you move on?
Sometimes you just have to move on. If the scarring, if you need to do an open capsulotomy, if the scarring is very severe, I mean, there are points where you just have to move on, and it's time to give up and open. And hopefully I can do a better open job procedure than the person who maybe had less experience. But, it's not an endless cycle of needle recurrence. Some patients are happy if they can get 2-3 years and come back with a partial recurrence.
Thank you.
Gary, there's 2 more questions just made it into the Q&A, and then we're going to have to move on. John Ord, you've almost answered this, I think. If you've got a patient who's had a couple of fasciectomies and radiotherapy, are you worried about doing these minimally invasive procedures? Can you still do a needle aponeurotomy on that patient, or are you worried about the circulation?
I mean, I worry about every patient, but I wouldn't worry about it. I think that if they had multiple fasciectomies, it's possible one of the digital arteries are out, and that's probably the side the disease is on anyway. So I'm going to live off of the other digital nerve, probably the radial digital artery for a little finger. When I do extend the finger, we do it slowly. The only fingertip necrosis, partial gangrene I've ever seen was with open surgery. So far, so good. In the United States, we keep our fingers crossed. But radiation is not a contraindication either for me to do needle or collagenase.
Okay, and very final point from Devin Scott. Is there a time when you give up? Someone's had so many recurrences, so loads of different treatments. Do you ever say, that's it, enough is enough?
I think at that point, I try to send the patient to see Paul Worker.
And I will definitely do a double fasciectomy.
I mean, look, you need to be realistic. It's a conversation with your patient, and you need to be realistic. It's obvious if somebody has multiple recurrences and they're coming back to the same point, you need to try something else. And, Dr. Sagan-Schmidt earlier had mentioned, and we didn't really discuss it, but we are doing some trials where we correct the finger using a minimally invasive technique and then use post-treatment radiation. And there's a couple of ROs in the United States that are running trials on that. Hopefully we report 5-10 years from now. And, maybe that could be something that would help us, especially for the patient who potentially missed a boat of treatment before.
So absolutely, come and hear about radiotherapy in 4 weeks' time. So it's not the next symposium, it's the one after. Please do sign up for that. Joachim, quickly, and then we need to move on.
I just think that we need to remember that in some patients, amputation is a good alternative at the end of the line.
A ray amputation of little finger is a great procedure for patients.
Remember
And
that.
I actually had a patient that had one and then came to see me years later, had moved to my area, had a bent finger touching the palm. And I said, I could do this, I could do that, I could do this, I could do that. She showed me her other hand, says, Doc, do this. And she has matching ray amputations.